Besides Representing Reese, Representing Clifford? I'll come back to you. Did you have one? Yes, ma'am. Go ahead.
Thank you, Madam Chair. I'd like to introduce 23 RS 0633 on behalf of the Behavioral Sciences Regulatory Board. It's a little bill, yes.
Very little bill. Okay. Representing Reese.
Thank you, Madam Chair. I'm introducing on behalf of Representative Reese Shue, 23 RS 0208. And this is prohibiting pelvic exams on unconscious patients without informed consent.
All right. Anyone else for a bill introduction? Representing Epley. You haven't done enough this last 2 weeks?
Thank you, Madam Chair. As we discussed, there's two bill introductions I have. The first is 23 RS 0757, which is diagnostic and supplemental imaging cost bill for breast cancer screening, introduced by the Susan Comer Foundation and their lobbyist, Michael Steiner. And then the second bill is 23.
Okay, just a minute.
Yes,
Okay,
ma'am.
on that one there, does that deal with, is that cost that's covered via insurance?
It is sporadically, but not consistently.
So it might be an insurance bill?
It could potentially become an insurance bill, and it could be standard of care for health care as it's rendered for breast cancer screening. Madam Chair.
Have you seen it, Scott? All right, we'll go ahead and accept it. Second one.
Thank you so much for accepting that.
Well, no, the only reason for those of you that
No, I meant that.
didn't understand my dilemma here is we try really hard not to allow bills to come into committees that aren't going to come back to these committees. And that's very important, especially in our exempt committees, because a person could get a bill put into, say, appropriations, and then it comes to me, well, that bill is blessed, which means it does not have a death time on it whatsoever. And that's why we worry about that. So you're fine.
Thank you, Madam Chair. The second bill is numbered 23 RS 0289, and it is the telehealth bill. It's asked to be introduced by KHA.
All right. Anyone else with bill introductions? All right, seeing none, we've got that off of our list. All right, first up, we have the Kansas Optometric Association. We had Todd Fletcher, Executive Director, Kansas Optometric Association, appearing before us today, and it looks like you brought us a guest. So announce to everyone out there on the World Wide Web.
All right, thank you very much. I am Todd Fletcher. I'm the Executive Director for the Kansas Optometric Association. With me here today is Dr. Shane Kanar. He's an optometrist from Pittsburgh, Kansas. And if it pleases you all, go ahead and give a brief update on the association and kind of what we do, and then Dr. Kanar is going to provide an update on the optometric profession. So the KOA is actually, and we say KOA, the Kansas Optometric Association, we talk about acronyms in here. My kids thought for the longest time I worked at the campgrounds, which is not the case, not nearly a school. But so the KOA has been around since 1901. We actually serve optometrists across the state. We represent the vast majority of the optometrists who both are practice and or are licensed here. We have a few folks that are licensed in other states but maintain their license in Kansas too, so that they can come back and practice later on in life or whatever. So we represent all those folks, and our doctors are practiced in all corners of the state. There's a few counties that we don't have an optometrist, but generally if that's the case, there's a doctor in the adjacent county over that does provide services. They practice in a wide variety of practice settings, from what you would consider maybe your traditional private practice where you have 1 or 2 or 3 doctors practicing together, to large group practices where they may have 20 or 30 optometrists practicing in multiple locations. Some of them work with ophthalmology in their practices. We have folks that actually practice in hospital settings at KU Med Center and Children's Mercy. And then we also have folks at like Irwin Army Hospital and the VAs where they practice, but also we have residencies there as well. So we do cover quite a wide range of the population for optometry. I've been at the KOA for 28 years, and in that amount of time, it's been really interesting to see how the demographics of the association have changed. When I started, most of the optometrists in the Kansas, majority of them were primarily men coming out of optometry school, and that has actually actually flipped. The majority of our graduates now are women. Probably 70 or 80% of the graduates from optometry schools across the country are now women. So it's just been an interesting change in the profession, and it's probably good for the profession to have a lot more diversity. The KOA's role with our members is to advocate for the profession. I'm come before you from time to time on different healthcare-related issues. Sometimes it'll be about telemedicine or different things like that. Last year, those of you that were in the legislature last year probably got to see me where we had some transportation bills where we were worried about driver's license vision screenings and the vision forms that doctors fill out, with some liability protections for optometrists and ophthalmologists when they fill those forms out. Also, we were dealing with school vision screenings. And we worked with a coalition of school nurses, optometry, ophthalmology, Lions clubs, and others to standardize the screening process across the state to make sure that as students progress through the schools in Kansas and maybe transition from one school district to another, that the screenings were consistent and nobody got missed. So those guidelines hadn't been updated since 2001, so it was time that they looked at, and then there was a process put together so that those are going to be reviewed regularly, and we're going to be part of that process going forward. So we try to advocate for our membership. And a couple of things, too, just to highlight some programs that I'm really excited about in Kansas that were started by optometrists here. One of them is called Volunteer Optometrists or Optometric Services for Humanity. It's called VOSH, is what we refer to it as. Actually started in Hillsborough, Kansas by Dr. Franklin Harms 50 years ago. And they provide charity care to populations around the world in underserved areas. And so that has grown over the last 50 years to have chapters in every state and all the optometric schools. And they actually have some international chapters as well. But we took a little bit of a hiatus during the pandemic, but I think this year there are 3 different missions that are planned to various parts of the world. And some of those are just optometry only, and some of those are in conjunction with ophthalmologists as well. So it's just a really great program, and it's, they get to take care of a lot of patients that have needs that wouldn't otherwise get served. Kind of the interesting thing with that, too, when I started, the thing that I found fascinating is that one of the things that they often did was they took eyewear that was used eyewear that they would take to these underserved areas. And I didn't know how the process worked, but if you were done with your eyeglasses, you got a new pair, you could donate them to the Lions Club. The Lions Clubs cleaned them and took them to the Hutchinson Correctional Facility, where they were sorted and repaired and put in good working order, and then they were categorized, and then they were able to be used in other countries. So it's kind of a great use of all the different resources that came together to help folks that didn't have other service. The other thing that I'm probably really proud about, because my wife is an educator, it's the See Learn program. We actually celebrate 30 years this year. This program is a program where optometrists were seeing a need for vision care for young children. They were seeing too many kids coming in junior high and high school for their first exam. Then they'd been struggling in school. And one of the common things that they kept hearing was that parents didn't realize that their children were not seeing as well, because kids assume everybody else sees the world the same they do. So they don't know that until they're 10 or 11 that there's some differences. So they just didn't know that they couldn't see well, and it was affecting their ability to learn. So optometrists created the See Learn program, where they provide a free vision assessment for any 3-year-old in the community, regardless of income or ability to pay. And to date, we've helped 100,000 kids. And about 15% of those kids over time have had a vision problem. So they were able to catch them and get those problems treated before they ever start school, which is pretty cool. The other thing that's kind of unique about it is because of the success of the program in Kansas, we actually have optometrists in Nebraska and throughout the Midwest that participate, and it's continued to grow over the years. So we're going to be kind of relaunching it a little bit with after the pandemic with our 30th anniversary to kind of bring a new and fresh kind of element to it. The interesting thing about it, we're starting to see the kids of the first kids come back in. So one of our offices in Augusta reported that a patient that he saw 30 years ago brought their 3-year-old in for an assessment, which is kind of cool. So with that, that's kind of an update on the profession. And I'm going to have Dr. Kanar give you kind of a brief update on optometry in general.
Welcome to committee.
Thank you. As Todd mentioned, my name is Shane Kanar. I practice in Pittsburg, Kansas. I've practiced in Kansas since 2006. And I just want to highlight maybe a little bit about our profession, some of the opportunities we see and the great things that happen in our state and really on a daily basis with our optometric providers in the state. First of all, when we think of optometry, I think sometimes we get caught up in vision correction, which I would never devalue and is a huge part of what we do as a profession. Helping people see with glasses and contacts, but there's so much more that happens on a daily basis that we tend to forget or maybe not talk about publicly as much as we should. There are a variety of eye conditions. I know some of you are more familiar than others, but glaucoma, macular degeneration are two that we discuss more routinely. The earlier we intervene, the earlier we initiate treatment, the better the outcomes are for the patient in most cases. Not only has that been true in the past, we're seeing more and more changes that allow us to provide better diagnostic ability and better treatment ability. And as optometrists, we can diagnose and treat conditions of the eye medically, not surgically at this point in time. We also work closely with everybody else on the medical team. And I know healthcare is shifting to a point where we think about patient care more in a team effort. Located where I'm at, we work with all the primary care physicians in our town. We work with ERs. I'm on medical staff at both of our hospitals in the county. And we work to provide what really is an encompassing patient care experience. And that can be twofold. One thing can be helping monitor known diabetics. Is there retinopathy developing? Is there signs in the eye? You know, the eye is the only place in the eye we can see vasculature without doing curettage. Are there signs that there are vasculopathies happening because of these systemic diseases? And the primary care will make them aware so they can modify treatment. There's also many times we see early on and maybe identify and diagnose systemic disease before there's other signs that the primary care physician will notice. And we're able to assess the patient and provide information back to the primary care doctor to let them begin workup and find the need for the patient. There's also emergent situations that occur. I mentioned we're on staff at both hospitals. That's because we cover the ERs. Kansas is so geographically diverse. It's not readily available to have ophthalmology in every county. Most eye emergencies that come in, we're able to manage at that point in time or make the appropriate referral, in our case, to KU or wherever it may be for surgical intervention. Those are the things we do routinely on a daily basis that have great impact on our patients' lives. We also oftentimes don't think about the education process that's required to become an optometrist. It is 4 years after 4, so 4 years of professional training. We're seeing more and more patients elect to do more and more students elect to do a optional residency. This training is on par with dentistry and podiatry and other health care professions that we see. It's exciting that we have these residency options available even in our state. And I mentioned that early diagnosis becomes more and more important. You know, we're seeing a trend in medical management and surgical management of patients to allow intervention to occur earlier with better outcomes, and there's no end to where that goes. We all see what's happening with technology and the ability to modify treatment for patients. Along with that, we're looking into different spaces and different avenues and different approaches that I think are so important. I know Todd mentioned telemedicine, and I think telemedicine is, as we discussed, is changing and evolving as with everything else. But I do think it's important that we keep what is the appropriate standard of care available as we work with the legislation to make sure that that happens. All this being said, there are challenges to our profession that exist across our profession as well as maybe unique or somewhat unique to the state of Kansas. You know, we see stagnant reimbursement occurring for all healthcare providers, and how do we incentivize people to want to continue to go into the profession? Being in a rural state, sometimes there are challenges getting people located into the less populous areas. And we think there's great opportunity to see and continue to do that. As we continue to modernize our scope of practice, as we continue to look at what we can do in the future and partner with technology, other healthcare providers, as well as other members of our profession, I think that what we can offer to an aging population, the delivery services we can offer, the treatments we can offer, continue to be more than optimistic. Are there any questions that we can answer?
All right, thank you very much. Committee, are there questions for either Todd or the doctor? Representative Clifford.
Thank you, Madam Chair. Thanks, Dr. Kanar. I'm an ophthalmologist in Southwest Kansas. I know we had Dr. Quinlan have health issues there in the Fort Scott. Are docs coming over from Joplin now to cover southeast Kansas, or has someone shown up to help you?
So I'll offer that in two parts. Even when Dr. Quinlan was in practice, Regional Eye Care in Joplin had a satellite office in Pittsburgh. Dr. Florkowski out of Kansas City actually purchased Dr. Quinlan's office. We work closely with him. He comes from Kansas City. I'm going to say it's a half day of surgery followed by a half day of clinic in Dr. Quinlan's office. We also have a Fort Scott office as well. And then Wayne Anliker from Emporia comes to our office one day every other week.
Thank you. And I would just comment that we in ophthalmology have enjoyed a very collegial relationship with optometry. I satellite to an optometrist practice in Northwest Kansas, and we in Garden City see from 6 states. So we see patients from optometrists in many, many states out west. So thanks for your work.
Yeah, and we appreciate that relationship as well. It's been wonderful. And actually, Mark Wallmeyer is a great friend of mine, and I think your office provided care in his region quite a while.
Thank you, Madam Chair.
Committee, are there further questions? Representative Reese.
I have a, thank you, Madam Chair. I have a question regarding the, maneuver my computer here, the See to Learn program for the 3-year-olds. I'm just curious about something. Can you test for depth perception in a 3-year-old?
There are things we can do to make sure that there's proper eye alignment. We can make sure that the ability for proper depth perception is there. As far as testing in a traditional sense, such as a stereo fly, or that becomes very difficult in a 3-year-old. We do the best we can. It's going to vary like everything you do with a 3-year-old.
Thank you.
Committee, are there further questions? Representative Berquist.
I'm speaking for a friend. There was a kid in our family that made it to his junior year and found out he couldn't see, and went through all the eye tests that the schools did every year. They put the chart up there, and I think this person had the chart memorized. But how does that happen? That eye test could have astigmatism, and astigmatism be completely missed?
So, you know, you mentioned the word eye test, but that's not a comprehensive eye exam. Yeah. Really, with an eye test, we're screening for a few certain conditions with a very high fail tolerance. Part of the reason the See to Learn program developed is you can slide by with astigmatism or hyperopia or mild myopia, eye turns, which strabismus, if we don't treat early, wind up in amblyopia. So I hate to say that's not an uncommon thing, but it is, and I'm sorry it happened to your friend, but I can tell you that as a profession, we want to do everything we can to intervene, to partner with school nurses, which we have great relationships with, to not only have screenings, but also comprehensive eye exams for the students across the state.
And that's what I was hearing from you. I just wanted to hear it from that perspective. Thank you.
Yep.
All right, thank you. Are there any further questions? Seeing none, thank you very much for being here today, and I appreciate it, Todd.
Thank you, guys.
All right, next committee, we have Dr. Stanley Gofarb. Did I pronounce that correctly? To discuss with us, let's see, do no harm. So welcome to committee.
Well, thank you very much, Madam Chairman, and thank you very much for this opportunity. You know, just before this, I had a chance to look around this wonderful state capitol building, and I saw this wonderful mural of Brown versus Board of Education. And I was thinking that, you know, we're in a state of regressing, not the state of Kansas, but the state of this country, in regressing back to that time. We're in a situation where healthcare is starting to look towards segregation as some sort of an answer for the way that we're going to have healthcare for the American people. So our organization is really devoted, this Do No Harm organization, it's a non-for-profit organization, devoted to countering this and making sure that healthcare continues to be really something that the rest of the world considers the optimum health care that's provided in the entire world through the American people. So I'm going to talk about 4 points fairly quickly, because I know our time is limited, about the problems we see with health care and what we suggest might be done about that. What we see is healthcare being turned into something where people are viewed as groups rather than as individuals. That's the underlying problem that we identified. And we see that there are 4 issues that I think need to be addressed. First of all, more and more workplaces are being turned into places where political ideology determines the way that physicians, nurses, and other healthcare personnel are going to progress through their careers and are going to be accepted into their organizations. And we know that in some states you have to take implicit bias training in order to get your license renewed. This is true in Massachusetts and in Michigan. And many organizations require their staff to take implicit bias training under the idea that this will somehow improve the outcomes for healthcare. And I'll get to that in a moment. We don't think that medical staffs and physicians and nurses should be required to have a particular political ideology, a particular political approach to the world in order to retain their positions. So that's our first point that I want to address. The second point is that there are healthcare disparities. Certain minority groups have much worse healthcare outcomes. And it's quite interesting to hear from the optometrists how important early intervention is in changing the outcomes for various medical conditions. And I think when one looks carefully at most of the medical literature on disparities in healthcare, in fact, it's due to the problem that individuals don't seek healthcare early enough. And this problem has become more acute lately because certain minority groups are told that organizations like the University of Kansas Medical Center, one of the great medical centers in the country, a place that I have colleagues that I've worked very closely with, that these organizations have tremendous racist problems within them, and they need to purge themselves of racism. And individuals, therefore, are going to have much less trust in the healthcare system if this, in fact, is the story that they're told over and over again. So I think when one looks at the medical literature very carefully and really evaluates it, you can find associations between social conditions and healthcare outcomes, but what you can't find is causal relationships between these. And the causes of poor health outcomes, for the most part, are poor access to healthcare rather than any sort of bias or prejudicial actions on the part of the healthcare staff. We think, and do no harm, that it's critically important to maintain the best, brightest healthcare workforce that we can possibly have. And right now, there's a movement to bring more and more minority students into medical school to sacrifice the students that have had the greatest academic achievements in the name of diversity. Now, diversity is fine, but when we talk about situations where we want to make sure that students have optimum opportunity, we often talk about a school and we talk about the student as if those are the two individuals that really are at stake here. But in healthcare, it's different. There's a third person in the room. There's the patient in the room. And we need to do what's best for the patient. If that means that students that are less academically accomplished don't get to be doctors, that's what we have to do. We have to have the best and the brightest. And schools that have started to sacrifice this, I think, are making a great mistake. And one example is your own school, the University of Kansas School of Medicine, and I'll just read a couple of things to you, but avoid reading. It has something called the Urban Scholars Program for students underrepresented in medicine. And the medical school engaged, as we say, in discriminatory practices, specifically violating the civil rights of students seeking admission to its Doctor of Medicine program. In their own words, quote, applicants must be a member of a population that is underrepresented in medicine, as defined by the admissions committee, including Native American, Black or African American, Hispanic, Latin, Latinx, Cambodian, Laotian, or Vietnamese. Students who enroll then complete this Urban Scholars Program receive assured admission to the University of Kansas School of Medicine, according to the program's official webpage. Well, this is an example of diversity trumping meritocracy in admissions to medical school. Now, I've worked with incredibly effective, I've worked with some of the giants of American medicine who are minority physicians. Dr. Lonnie Bristow was president of the American Medical Association. Dr. Ed Cooper was one of my heroes at University of Pennsylvania. He was chairman of the American Heart Association. Dr. Ben Carson, many of you are aware of, was one of the premier neurosurgeons in the United States. And Dr. Jerry Thompson was the president of the American Board of Internal Medicine. I served on that board during my clinical days. These were giants of the field, and if we had a medical school class that was entirely made up of minority physicians, that would be wonderful, as long as they were the most qualified, the most talented individuals that came to the medical school that year. But unfortunately, that's not the case. We're sacrificing that, for example, by schools saying that medical college achievement tests aren't required for entrance into medical school. The Medical College Achievement Test was instituted in the 1930s to make sure that only qualified individuals could get into medical school, because they would flunk out, and the idea was to avoid that. But in fact, there are many schools that are now bypassing this important admission qualification in order to increase the diversity of medical school classes. And lastly, I would say that our organization is really devoted to preventing any discriminatory practices in healthcare. And there are several examples now where discriminatory practices have been instituted. And the basis for this is treating patients as if they're members of a group, as opposed to individuals who come in with their own needs, their own problems, their own clinical problems that we need to address. When I go into a room and see a patient, I don't think, well, which group is this patient a member of? And I don't want to treat them as if they're a member of a group. And yet, we've had examples of this. One prominent one was at Harvard, one of the Harvard hospitals, at the Brigham and Women's Hospital, where a protocol was put in place where minority patients were admitted to, were given a choice of being admitted to the cardiology service or the general medical service, because historically, more minority patients had been admitted to the general medical service than to the cardiology service when they came in with a particular form of heart failure. White patients were admitted more commonly to the cardiology service, and that was viewed through the lens of critical race theory, and we were told this was due to bias. It wasn't due to bias. It was due to the fact that the minority patients had a clinical problem, kidney disease, that was better handled in the general medical floor, and the white patients tended to have primary cardiology diseases, cardiac diseases, that were much better handled in the cardiology specialty service. So our organization feels like that this kind of discriminatory practice shouldn't go on. We saw it very evidently in the pandemic, where there were situations where scarce drugs were being reserved for members of one minority group compared to another group. Again, we shouldn't be treating patients as members of groups. We should be treating them as individuals. If a patient came in with COVID-19 and the best therapy for them was a particularly scarce drug, we should use that unrelated to what their ethnic background is. And I think most people would think that's fair, and that's the way medicine ought to be practiced. Otherwise, we're going into an ethical dilemma that I think no one wants to really see. So those are our points. We have in the written testimony that we've given a number of examples where Kansas institutions of higher learning who train people to be part of the healthcare system have gone down this path of focusing on the group characteristics of individuals as opposed to their individual merit. And I'll just finish by reading you a statement from the website of the Kansas State Pre-Nursing Program. To just show you what the problem is like, they seek to, quote, require demonstrable commitment to diversity as part of their tenure and promotion process. So normally the people who get promoted are people that have demonstrated their ability as teachers or researchers, and that's been the only qualification. Now there's a new qualification, and that's going to be their ethnicity. Also, they're going to seek to assess and evaluate equitable salaries and pay compensation that considers cultural identities, gender, race, and ethnicity. And again, people should be paid for the job that they do, and this consideration should not enter into it. So again, going back to that mural up there, I see us in a regressive state. This is not a progressive kind of idea. This is a regressive idea. This is an idea that we're going to lead back to a segregated healthcare system. And I think all of us see America as a place where everyone should have the same opportunity. Everyone should be treated the same. and it should be independent of these factors. And I think that's what Brown versus Board of Education started to accomplish, and here we are 70 years later, and hopefully we're much further along so that we can allow that to occur. So thank you very much for your attention. I'll be happy to answer any questions.
All right, thank you. Committee, are there questions? Representative Clifford.
Yes, thank you for being here today, and I enjoyed hearing you at lunch. I practice in a predominantly Hispanic area. It's fortunate that I speak Spanish, but my assistant is Native American and doesn't speak Spanish. But when I'm speaking to the patient, they look at her, and I translate. So I see value in having a brown-faced doctor or a black-faced doctor, a culturally appropriate doctor in the room, or nurse or other healthcare provider. Where might we intervene earlier in order to get those folks qualified, highly qualified, so they can compete on an even playing field for these positions?
Yeah, I make a couple of points. I think that's absolutely right. I think the problem is to make sure that they understand that there's a career in medicine, and the best and the brightest kids that have the capacity to pursue this, that have the quantitative abilities, ought to be encouraged early on. So certainly, getting into the grade school and high school level is an important part of this. I should point out that it's been very difficult to recruit minority students into medicine. My own school, the University of Pennsylvania, has tried for the last 10 years to increase the number of students of various minority groups, and they have failed in this. And I think part of the problem is there's not all that much interest in it. So again, declaring that our organization is racist and declaring that our organization now has to change the qualifications for medical school in the face of those problems, I think really doesn't make a great deal of sense. I understand that patients may feel somewhat more comfortable dealing with people that look like them. That's clearly understandable. The question is, how far do we want to go down the path of creating circumstances where that's the key outcome? I think, to me, the key outcome is that patient getting the best care possible. And I think we need to do everything we can to make them comfortable so that they understand that. But the more and more we speak about the need for anti-racist activities, the more distrust that occurs, the more you're going to see situations in which patients are seeking that out. And I don't personally want to be part of a medical institution or even a country where white people come in and say, you know, I want a white doctor. And black people come in and say, I want a black doctor. And so other minority groups all seeking a particular physician. The question is, are they going to get the best care when they come into that institution? And that's got to be what we focus on.
Thank you. Thank you, Madam Chair.
Representative Boyd.
Thank you, Madam Chair. It's not lost on me that this is the first day of Black History Month, and I'm sitting through a presentation and someone is representing that diversity, equity, and inclusion is a bad thing, and that institutions shouldn't be trying to be intentional about increasing representation. I think I heard you say that diverse students are less capable. Sir, that's quite rich, and I am deeply offended by your presentation. Madam Chair, if you'll indulge me, I have a couple questions. On your website, sir, your organization describes its goal to fight anti-racism. Can you help me understand why your organization would advocate for racist policies and practices?
Well, thank you for the question. You know, anti-racism has been described by Ibram Kendi as an activity that uses present discrimination to deal with past discrimination. And certainly past discrimination was terrible. We accept that, and that was an awful thing, and that's something that really does need to be redressed. But his solution, and the solution of anti-racism, is present discrimination, and he says that present discrimination, the remedy for that is future discrimination. So anti-racism is really a phrase that it speaks about creating a new kind of racism, a racism where individuals are put into separate organizational groups, separate identities because of their race. And I think that's something, again, that Brown versus Board of Education really sought to eliminate. So I don't think our organization is advocating for racism. Our organization is advocating for a true fight against the racism that's involved in separating people out based on their identity with a group.
Madam Chair. So you're using one person's idea and painting this broad brush across multiple people of color. But here's my second question, though. I'll move on beyond that. It's related to health disparity among Black Americans. In the state of Kansas, Black babies are three and a half more times likely to die than white babies. The National Academy of Medicine released a report that said, regardless of racial and ethnic minorities, they released a report that said racial and ethnic minorities received lower quality health care regardless of their income status, their insurance status, age, and severity of the condition. Is that okay? Should institutions not seek to try to get rid of that disparity?
Yeah, of course they should. And when one examines the whole question of maternal mortality and infant mortality, what one finds is the vast majority of minority women, of Black women, do not get prenatal care in the first trimester. And a large percentage of them don't get prenatal care in the second trimester. Now, when you get to the third trimester, more of them get prenatal care. But the high rate of maternal mortality in Black women, and that relates very closely to the high rate of infant mortality with Black children, is because that prenatal care is not provided early enough. The biggest medical problem associated with those individuals is cardiovascular problems. Most of the deaths occur between 6 weeks and a year after delivery. Most of the deaths are associated, if at the time of delivery, with preeclampsia, eclampsia, which are conditions of severe hypertension, which are associated with the lack of adequate prenatal care. So almost the entire problem of care of outcomes in the Black community vis-a-vis birth and infant mortality is a function of lack of access to health care, lack of early access to prenatal care. There also are genetic factors that are involved in this. There are certain genes that if both parents can have that gene, and the genes are a question of geographic origin in West Africa for a large population of African Americans in the United States. If you have 2 copies of that gene, there's a much higher risk of early delivery, of premature delivery in the children, again, which is a big factor in increased infant mortality. So almost all of the problems that are related to higher maternal mortality and infant mortality related to 2 factors. One is lack of early care, and the second problem is a lack of hospitals that are trained to care for individuals who have severe problems and complications at the time of delivery. And I would urge you to look at, also there are other reports of this. There's a state maternal mortality assessment group that goes in and examines each death that occurs to a woman who has a death at the time or related to delivery. And you can see that the data clearly show that the vast majority of these patients have severe underlying medical problems that are the cause of their either premature mortality or the premature delivery, which is associated with high infant mortality.
We must be looking at different data. I guess we'll just agree to disagree. Thank you, Madam Chair.
Committee, are there further questions? Representative Haswood.
Thank you, Madam Chair. As an Indigenous person, I also went to KU Med too. I'm Native American, and I didn't go to medicine route, but went my master's in public health on a Native American scholarship. Very appreciative of it because I was probably only one of 5 or 10 in the whole medical school. As an Indigenous person, we have a very dark history, and being Native American, we're already in this political system already, whether we like it or not. You know, from 1492 with genocide and political policies by United States government, and then later states governments. You know, something like the Urban Relocation Act that was advertised to Native Americans as a nuclear family, moved to Kansas City, moved to LA. In 1952, only 71 years ago. Not that long ago. I'm 28, so a lot of these policies still impact my life every day. You mentioned Brown versus Board of Education. That was very recent events that we're still trying to evolve from. You know, here in our current political system, there's a battle of public education versus private education, using state funding for private education. And, you know, those types of private education folks can pick and choose who go to those schools. So I don't see when you say folks should be at the same academic level when there's already these systematic racism against us from education, from where we live, from redlining, that are all less than 100 or so years ago. You know, even Native American women had forced sterilizations from the United States government. That was only 47 years ago. You know, when I looked through your website and I heard your presentation, I didn't hear any, you know, how does this gonna impact and improve the lives of Kansans' access of healthcare? How are we gonna get more folks into medical school with a diverse background? Can you give me some policy examples or recommendations, some solutions to fix these issues when we're already trying to deal with systemic racism? Even for me, being the only Native American in the Kansas State Legislature and trying to improve Indigenous lives, it's quite difficult when my colleagues don't know our history. So can you give me some policy recommendations from other states that we can try and improve the access and quality of Kansans?
Sure. Well, thank you for that question. I would say one thing about the access to medical education. Now, medicine's a little bit different from those other opportunities you talked about. I agree that you need to get students at the level of colleges, and that's been the big barrier. But now we're talking about students that have gone through 4 years of college. And at that point, I think the expectation can be that they really should be capable of passing these exams and performing well in college and not needing to have not needing to be admitted with academic performance that's less good than other groups, which this is an objective observation that came from the AAMC, who put out data on the MCAT achievements, the achievement test scores, as well as the grades of minority groups that were accepted to medical school compared to majority groups. And there are substantial differences, very large differences, and we can't ignore that. So at that point in their careers, should they be capable of having the same achievements? And I think that's a question to be asked. In terms of policies, my own personal belief is that this is all about healthcare access. I think institutions need to make healthcare accessible to various communities. And this, from a physician standpoint, I think this represents facilities, whether it's mobile units that go out into communities and provide services for people, pick the diseases which have the highest complication rates. Breast cancer is one good example, to have vans that go out into the community to provide the opportunity for examinations and the opportunity for mammography that can identify the problems earlier. I think access is the key. If we don't improve healthcare access, if we don't improve these institutions extending themselves out in the community. Now, our point is, one of the important points is, what's the best way to accomplish that? The best way to accomplish that is you have to spend resources. If you spend your resources on this idea that the institution has poor health care outcomes for minority groups because the physicians are biased, and you're going to spend your time creating a large bureaucratic enterprise that's aimed at this so-called racism that's endemic in the institution. If you send your trainees for all these courses, if you waste time in medical school training about this, when you should take that money and devote it to increasing the healthcare outreach to the community, you'd be a lot better off. One example is University of Michigan spends $18 million a year on their healthcare, on their bureaucracy associated with diversity, equity, and inclusion. This is published information. That's a lot of money. And the question is, what's the best way to spend $18 million if you're trying to improve the health care of your community, or you're trying to improve the education that gets people into the opportunity to be physicians? I understand. I feel badly, and I've had some, as I try to mention, there are some African-American physicians that I hold as my real models, people I work with and have great respect for. It's not about that. It's about what their academic achievements have been and what they're capable of doing as physicians. And there is a very good correlation between performance on these exams, performance in medical school, performance in residency programs, and that's where it stops, because we don't have a lot of information on physician performance beyond there. We just don't. But I think all of us would say it's very likely that the ones who perform the best in those settings in training and education are the ones that are likely to be the most effective physicians.
Thank you.
Representative Vaughn.
Thank you, Madam Chair. My question is related to healthcare access, something that you keep talking about. And I'm wondering what you think the cause of unequal access to healthcare is. And I ask because, as has been referred to today, arguably it is systemic racism, a system that has historically failed to, and even now fails to, provide adequate access to healthcare for minority patients. So how do we address unequal access to healthcare if we don't address the underlying reason for that unequal access? And that applies to outcomes too. If we have unequal access, it's contributing to unequal outcomes. And I don't think you can address unequal outcomes without addressing the reason for that, which is systemic racism.
Well, and then it becomes the question of exactly what the definition of systemic racism. If you say the problem is they live in communities that don't have healthcare facilities, and you want to call that systemic racism, okay, I mean, you can, any definitions that you want. The problem that needs to be fixed is increased access to facilities, increased facilities in the communities that have these problems. And the other thing, you know, for an example, let's say a woman is working 2 jobs, is a single mom, she has a medical problem, and she's not free to get health care except at night. Well, these large institutions and healthcare enterprises need to provide nighttime services to these patients so that they can get access to health care. That's one example that would make a large difference. The reason that many minority communities spend so much time using the emergency room as the source of their health care is because it's open and it has good services, and that's where you need to go. But it's hardly ideal. There's no continuity of care associated with that, so that's not the answer. The answer is facilities. The answer is access. The answer is using telehealth, as you heard about a little bit, to sort of improve that. At the University of Pennsylvania, the use of follow-up appointments after surgery by minority patients was only about 60%. Telehealth elevated that rate up to 85%. So that was one example of being able to get follow-up, and a lot can be accomplished using telehealth if one has the facility. So I think it's up to legislatures to really prod institutions and the people of Kansas to prod institutions to make sure that the healthcare facilities are available to patients. Our point is that understanding that these differences in outcomes, if you decide that that's due to bias and poor care on the part of physicians, once patients show up in the healthcare system, there really is absolutely no evidence that that's true. There's absolutely no evidence that that's true. People find disparities, and they find social conditions, and they say, well, that's the cause. But the link is not there. The link for that mechanism is not there. And almost invariably, when you start to dissect these issues, it has to do with when they come to get care, some of the factors about lifestyle factors, some of the factors are genetic. Very, very little, if any, of those factors are due because of conscious or even unconscious differences in the way the healthcare is administered. And I think there have been very careful studies to show that when minority patients and white patients, for example, during the COVID epidemic, if we match those patients up and saw what their clinical outcomes were, once they were hospitalized, the outcomes actually were better for minority patients. And the issue is to get to the healthcare system early, not to wait until you're so ill because you don't trust the healthcare system. That's been an important part of the problem. So to me, the answer is really access. And the answer for access is how governments and private institutions decide to improve access to patients. If they improve access to the healthcare system to patients, these disparities would be dramatically reduced.
I certainly think investments in access is important. I'm just making the point that unless we address why that disparity exists in the first place, it's doomed to repeat itself. And that's why I think DE&I and these sorts of practices are extremely important. Thank you.
Thank you.
Representative Reese.
I have to admit that I'm still confused about why you're here and why you're making this presentation. I have before me what you have presented to the committee in your statement. So my first question is, why are you here, and what do you want from us?
Well, you know, our organization is devoted to doing a few things. One, we want to inform the public. And this represents informing the representatives of the public, so that's an important effort for us. Secondly, we want to see certain outcomes that occur in various states that improve this situation. For example, I'd like to see the state say that make sure that physicians don't need to write DEI statements in order to get promoted at their institutions, that they don't need to accommodate a certain political idea about how to improve healthcare, how to improve the quality of outcomes for various minority groups, that they don't need to do it through a single pathway. For example, if they advocate much more for increasing access and not for implicit bias training amongst the faculty, I think that's something that they should be allowed to do and not be penalized for. So that's something that's expected of them now in order to gain their promotion and even tenure at certain institutions. We want to see transparency in medical school admissions. We think the public should know what's the basis for accepting students into medical school. And if the people want that, if the people want this sort of thing, but when we've done polling, the public does not want that. The public thinks that meritocracy should be the basis of admissions into medical school. Again, medical school is different. There's a patient in the room as well as the school and there's the student, which is different from most other educational circumstances. So those are some of the things that we want. We'd like to see less money spent on these DEI activities in medical education and in healthcare systems, and we'd like to see that money devoted to improving access to healthcare, to fixing the problem that actually exists. So those are some of the things we'd like to see the legislature take up, and we're going to try to urge legislatures around the country to do that.
Madam Chair, can I have another question? Thank you. I see that you've got 5 key policies that you're promoting. And the first one is require medical schools to certify they are not requiring applicants and students to ascribe to anti-racism, critical race theory, implicit bias, equity, social determinants of health, or DEI in admissions and education. Can you please say more about that statement?
Sure. So we did an evaluation of the application process in virtually all the medical schools in the United States. And medical schools across the country have two aspects to the application process. One is this formal application where you put in all the demographic information. And the second one is a question. And almost invariably, in over 80% of medical schools, we found that the questions that are asked are simply ones that suggest that a student has to ascribe to these approaches to solving social problems. To the approach is that, what have you done to reduce anti-racist activities previously in your career? For example, that's the sort of question that's asked. Well, we don't know that if you answer those questions negatively, you're not going to be accepted into medical school, but I can tell you that medical students feel under great pressure. We have many of them who are members of our organization that feel they're being pressured about these issues all the time, feel very uncomfortable about it, and don't see that as the solution. They see, for example, increased access as the solution, but not to beat their chests and claim that they've been racist all this time, and now is the time to rid themselves of all this racism. So those application questions have been part of the entry into medical school, and we feel that that's not right, and that students should not be asked to ascribe to a particular political philosophy in order to gain an entrance to medical school.
And so you're ascribing this to a specific political philosophy?
Well, I think that's right, yes.
Okay. I would suggest that you change your name from Do No Harm to something else, because you are doing harm. And whether you agree with that or not, whether you are able to even understand that, it's up to you to be more conscious about the practice of medicine. See, you're talking about the entrance, but you're not talking about the practice of medicine. And as a person who accesses healthcare all the time, I have faith in my providers and I have faith in their training. But I don't ask them, what did it take for you to enter into medical school? Because what's important to me is who is before me and who is considering all of me. So if there is something, then I'm Latina, and we know that there are some health risks for certain cultural groups, my doctor will talk to me about that, and I understand that, and that makes a connection that I have with her, knowing that she understands me. So I think your group is providing much more harm to the public than you think you're doing the opposite, and you're not. Thank you, Madam Chair.
Representative Burkamp.
Thank you, Madam Chairwoman. Just curious, I know some medical professionals get in the field to make money, but I think a bulk get in it just to help people who are, having issues. So I'm just curious, have you seen any evidence or have any data that says people are leaving because of like extra things besides medicine that they're having to do, more political as opposed to just practicing medicine? Thank you.
Yes, thank you for the question. Yes, we have. Now, we're a membership organization. We have over 3,000 doctors that have communicated with us now. Not all doctors, but healthcare professionals, almost exclusively nurses and doctors. Yesterday, we got a notice, just an anecdote, I understand, because it's very hard to collect data on this sort of thing. We had an anecdote from a physician in Maryland who decided not to join a practice, young man, not to join a practice because he was asked to go through this training, and he felt very much upset about the idea that he had to go through this training, this implicit bias training, because he felt very strongly that that's not the way he dealt with his patients. And, in fact, we have a number of physicians that have talked about this, and one of our activities is a lawsuit against the federal government that's demanded that anti-racism practices be employed for Medicare patients in order to increase the payment that physicians would get through Medicare. And we have a couple of physicians who've just felt very much upset at this because they felt like they wanted to treat all their patients the same. They didn't want to create separate pathways for patients based on their ethnicity, which was really what was demanded by putting in some sort of so-called anti-racism protocols in their practice. And they're the plaintiffs in these lawsuits against the federal government, which, by the way, 8 states have now joined and is working its way through the federal courts. So we know anecdotally that many physicians are upset about this. I think one of our goals in the coming years is to actually get polling information to be able to tell the public just exactly how the medical profession feels about this. But there's a great fear out there because if you express some of the ideas I've expressed today, your career is at great harm. And that's a problem because it represents sort of a lack of freedom of thought in this country, and that's something that we feel very strongly about.
Representative Orpeza.
Thank you very much, Madam Chair. I wanted to piggyback off of Representative Ruiz's comment about what is your take and idea of cultural competent care in healthcare delivery, and as well as your take on rural disparities present in our healthcare today?
I'm sorry, rural disparities?
Rural disparities
Yeah.
as well as cultural healthcare competency.
Yeah, well, let me say about cultural competency is that I think medical students need to be aware that there are a lot of cultures that they're going to see. In my community in West Philadelphia, where my wife used to teach in an urban setting, she had students that spoke 120 different languages. So to me, if you say, well, we want cultural competency, it's, well, which culture are they supposed to be competent in? What they need to be is responsive to the patient's needs, to solicit those requirements. If you need be aware that if you need a translator to get the accurate information, that make that available. But the idea that there's going to be a course that's going to allow them to understand all of these different cultures, I think is really wishful thinking. Now, mind you, when I ran the curriculum at the University of Pennsylvania, we had a course that went on for a long time in cultural competency. I'm not against these courses. What I'm against is a further expansion of these activities with the goal of creating physician advocates, which is really what many of these organizations are about, and absolutely put that in front and center. Groups like White Coats for Black Lives as an organization is to create physicians that are going to be advocates as opposed to changing the practice of medicine. Now, as in rural medicine, again, I don't have solutions. I come from a big city, as most physicians practice there. I've lived in the East Coast. I think the one potential solution to this, as you heard from the optometrist, is telehealth. I think if there's one possibility for improving healthcare outcomes in individuals that don't have access, particularly to specialty care, it's that. We need to use technology in ways that will improve healthcare in that way. There's no magic solution. Healthcare is very expensive, as you know, and these facilities can't be scattered all over the place, and unfortunately, that's reality. So the trick is to bring them technologically to rural environments, and I think that's the best hope for it. And with great advances in artificial intelligence and in telehealth, I think the opportunity for improving healthcare in rural environments will be there. But again, I'm no expert in that area at all.
Representative Epley and then Representative Blacks.
Thank you very much, Madam Chair, and thank you, Dr. Goldfarb, for being here. I want to give you a little background information and lead to some questions. I have practiced in this state in primary care for 42 years. I am an alumnus of University of Kansas School of Medicine. I've served on their acceptance committee for many, many years. I don't do it any longer, but I've done it for many, many years. I've accepted students into the Urban Scholars Program and also into a program you didn't touch on, which is the Rural Scholars Program. So I think you and I are coming at this from probably, I hate to say, but probably polar opposite directions. It would appear to me that you're taking a national narrative and trying to adapt it to our state of Kansas and how we conduct ourselves as far as trying to build up our access to care. And that's really the key thing here. You really preach a lot about access. And yes, telehealth is a tool in that, but access has become just an impossible burden in the state of Kansas, and hence it's led to policies that you touched on that relate to diversity, equity, and inclusion, and also these programs that you take exception with that, at least on the surface to you, appear to trump, what'd you say, I think, diversity trumping meritocracy. And I can see how you might reach that conclusion, but have you had any ability to interview or talk with Dr. Gerard or Dr. Rob Samari or anyone at KU Medical Center or Bob Page, the CEO, to get confirmation of some of the allegations that you threw out there today about KU? Have you interviewed anybody from the school? I'm just curious.
No, we haven't, sir.
You haven't. So you made these comments based on what you see on a website or an internet site about these programs. Is that correct?
Yes, that's correct.
When you review these programs, do you see that they go through all the standard applicant processes like all other applicants? Did you observe that?
Again, I would just say that what we're really doing here is talking about the initiatives that are coming down the pike. You know, for example, if I may.
I don't know if that answers my question.
Well, we haven't specifically.
So what is the MCAT score average that they request for the Urban Scholars Program and for the Rural Scholars Program? Do you know that?
I don't know that, sir.
Well, how can you talk about lowering the standards if you don't know what they are?
Well, I'm just pointing out, sir,
well,
that
you're impugning us for how we conduct ourselves, and you don't know what the standards are at the University of Kansas School of Medicine. I know what they are because I've sat there and I've interviewed those students, and I'm troubled over you undermining a program that is a hallowed program that actually increases access because it puts students where they need to be, which is in urban core centers and in rural core centers. And the standards are very similar for both programs, and they're very high. And you know, the MCAT scores are 500. They're not world class, but they're pretty high scores. The GPAs are above a 3.25. I've researched this, I know this, and you can't even get an interview for that. I've seen students cast out of both programs because they didn't meet minimum requirements. So to say, for you to tell us, to tell this committee that we accept everyone and we never turn anybody out, that's not true, sir, and I want to make sure that you understand that. And the idea is that when these kids from farm communities, and I'm from a farm community, I raised hogs, okay? I wasn't in the scholars program. I had to do it, you know, the old-fashioned way. But we get kids that are from rural areas that go back to those rural areas to provide access to care. And it bothers me that you're preaching about access when it's really the opposite, because what we had prior to about 25 years ago was a brain drain in the state. We had a bad brain drain. We had a lot of kids that we were accepting that were, you know, on the face of it, one type of student, and they all left the state, and we didn't have enough physicians in the state. So we had to develop programs, not with lower standards, but that were more focused on developing talent in rural areas and urban areas. Now, the implication that I think you've made is that they are inferior quality. And I want to stress, I really want to stress to the committee, they are not. We're taking these students as juniors and seniors in high school, and we're helping you know, you can use the word groom, whatever you want to use. We're helping educate them so they can be high achievers and meet the standards of the University of Kansas School of Medicine. But for you to tell this audience and this committee that we're taking an inferior product, I think is a gross oversimplification. Now, to say that it's perfect every time and we always take the very best students every time, I can't sit here and give you that opinion. But I am troubled that you've given this perception when you don't know the standards. You haven't talked to anyone at those institutions. I would ask you, have you talked to Richard Linton at K-State University, the president of the university, when you impugn all the issues going on at K-State over diversity, equity, and inclusion? It troubles me that you're taking a national narrative and then morphing it into a state narrative for which you really don't have, no offense, it appears to me you don't maybe have all the information. And I'd be curious for you to give me some feedback on that, sir. Thank you. Thank you, Madam Chair.
Well, you know, I accept your criticisms. If we're wrong about Kansas, I certainly would apologize to that. I would just point out that a 500 score on the MCAT is an average score. That means that half the students who applied had higher scores. And I would point out that in the United States, there are 2 applicants for every spot in medical school. So this is a very severe funnel. And it may very well be that these students are getting through medical school. I can tell you, as someone who has supervised a curriculum, the requirements for getting through medical school have been dramatically reduced. And the requirements for getting into residency programs have been changed quite dramatically. For example, the scores that used to be used in the Part 1 of the licensure to identify the best and the brightest students are now pass-fail, because the problem was that enough minority students were not getting into the jobs that they wanted. And so it may very well be that the only way you can have students that practice medicine in rural Kansas if you accept students with MCAT scores that are below half of the students that are applying in the United States. I would argue that I think that programs could be put in place that would encourage individuals, for example, loan forgiveness programs, for example, that those students that perform much better on the MCATs and have much higher GPA averages who are not getting into medical school now would be interested in going to a place like University of Kansas if those opportunities were afforded them.
Thank you for your comments. I would only tell you that the mean score of the MCATs of those students in those programs is above 600, but the minimum is 500 to at least be able to apply. So that's just for an application. That's not acceptance. So again, I don't want people to think we're dumbing down in this state, but we're trying to have a program that meets a subset of people, whether it's indigenous people or black people, or whether it's people in rural areas. We're trying hard. The University of Kansas is trying hard to meet the access needs by getting people there that are committed to go there through this process of higher education in the state of Kansas. And I'm just troubled, I mean, that you've taken a national narrative and tried to drill down on our institutions of higher education without knowing those standards and without interviewing people that work at those, because I think you might have a different impression. So thank you for your testimony today.
Yeah, and I would just like to say, if I may, Madam Chairman, that I have great respect for the University of Kansas. As I've said, I have colleagues there. I have great respect for it as an institution. I think these national trends are actually national trends, and that the organizations that govern medical schools are expecting these kinds of activities in every medical school in the country. So while I may be wrong about certain aspects of Kansas, and I apologize for that, I can tell you that these are national trends that are occurring, and that's what our organization is really trying to push back against.
All right. Representative Bueller. Or I'm sorry, Representative Barth.
Thank you, Madam Chair. Just had one question for you. Of your members, how many of your doctors are from Kansas, your physicians?
I can't tell you that, but I'll be happy to get you that information as soon as I get back. We don't have a roster that way, but we'll try to organize it. Our organization has started back in April of this past year, so we're still getting the ducks in a row. But I will be happy to get you that information.
Okay.
I know I certainly I had a nice conversation with one of our members from Kansas just yesterday, so I know we do have at least one.
Representative Blacks.
Thank you, Madam Chair. Thank you for your presentation. I guess I'm socially disadvantaged. I come from a one-room school and I was the only boy at 5 years old and 7 girls, and I had to carry the bucket of coal. So, and I don't have 42 years of practice experience in much of anything, but here's what I do know. When I'm hurting, I want a good qualified doctor. And I don't care about anything too much else other than the fact that if I'm hurting, I expect that person to fix me up. So at my age, I need that. So thank you.
Thank you.
Committee, further questions, comments? All right, seeing none, thank you very much for being here today. We appreciate it.
Thank you very much. It was very, very good. Very good questions.
All right, let me ask you a very crucial question. Does anyone have a bill in the works that they were planning on introducing on Monday? Huh? Maybe? Huh? No, Monday's the deadline.
That's it for this
For this committee.
committee.
Yeah.
You could introduce another committee.
You might have, huh? Okay. Is Scott working on them? Oh, on the Senate side. But you're not going to introduce it. Okay, well, what we're trying to decide is whether we meet Monday or not, because right now, I don't have bills scheduled. Now, that doesn't mean that won't change sometime this afternoon, because if the timing works right, we may have some bills that we'll be able to tee up for Monday. We're running up against deadlines. Monday is the last day that we can introduce any bills in this committee. So that means the revisers have to have them, and you have got to have had an RS number, just like what we did earlier today, if that makes sense. So we may or may not meet Monday, but the first thing I got to worry about is if anyone's got bills, because I don't want to deny anyone the opportunity to introduce a bill if they've got one on Monday. I could have Representative Epley come down here and anybody else that was interested, but I may not show. Of course, oh, that's right, I don't show in the beginning anyway, so we're going to let him. What did you just say down there?
Madam Chair, I check your hearing. Thank you.
He's not a hearing doctor, he's an eye doctor. Oh, my gosh, we're in trouble now. So does that make sense to everyone on the bill issue? That's what we're looking at? But I would pay attention to the agenda, because like I said, if we get our bills this afternoon that we are expecting, we will be having hearings on Monday.
We could have just a meeting to do bill introductions on Monday.
No, I know we could.
You could even do it at the rail.
If I wanted.
Rail restaurant.
Okay, so, well, and Scott's right. We could do it at the rail, and for those of you that are new to that, that means that we walk out of our chamber, walk to the rail in the middle of the rotunda, and our little committee meets. Our staff follows us. They listen to what we say because they've got to know what we're doing or what we're attempting to do. And we could do a bill introduction. So for right now, I would say if something comes up between now and Monday, you've got to have an RS number, correct, Scott? Take and let me know Monday morning. All right? But still pay attention to your agenda, because like I said, if we get these bills back like we think we're going to, we'll be teeing up bills, because we've got this week and the following week to finish all bill introductions that we have in this committee. So, all right, we are adjourned.